without further ado, would like to introduce our first speaker. This is Julian Gillmore. He is, let me get this. He has been in the field of amyloidosis for many years, and his research interests include pathogenesis, diagnosis, and treatment of amyloidosis. He was appointed the center head at the University College of London Center for Amyloidosis and Acute Phase Proteins in 2019. And his research, he's a research lead at the UK National Amyloidosis Center. He has published more than 250 peer review articles and has supervised a number of students throughout their postdoctorate research degrees. He is a PI on a number of studies and is really a world leader in the current treatment of amyloidosis. He is going to be speaking about, let me get the title, how to diagnose and when to suspect amyloidosis. Dr. Gillmore, I think you can take it away.
Thank you very much. So thank you very much indeed for that very kind introduction. It's a great pleasure to be here. Can I just check that you can see my screen?
Yes.
Yeah. The wrong bit of it, but there we go. So apologies for that. So it's a great pleasure to be here. So I'm going to kick off, I think, by talking about when to suspect and how to diagnose amyloidosis. And in terms of the outline of my talk, I'm going to give a very brief introduction to amyloidosis in general. I apologize to most of you who will know most of what I'm going to say there already, but I'll talk a bit about some of the diagnostic challenges that we face in amyloidosis, and then hopefully talk about some of the advances in diagnostic methods that have led, I hope, and will continue to lead, I hope, to earlier and more accurate diagnosis. So amyloid is an abnormal extracellular misfolded fibrillar protein deposit in the tissues, which is characterized by green birefringence when you stain that tissue with Congo red and view it under cross-polarized light. So you can see amyloid deposits here, stained with Congo red and viewed under cross-polarized light. And there are in fact more than 30 different proteins that form amyloid fibrils in vivo, and they form the basis for the classification of amyloidosis. So for example, in AL amyloidosis, the amyloid fibril protein is a light chain of immunoglobulin derived from a monoclonal excessive production from typically a plasma cell dyscrasia or a monoclonal gammopathy. In AA amyloidosis, the amyloid protein is a protein called serum amyloid A. That's an acute phase protein, exactly like C-reactive protein, which goes up and down in line with CRP. It has a wider dynamic range. And in order to get AA amyloidosis, you need a high concentration of this protein, serum amyloid A, in the plasma for usually at least several years. And then transthyretin amyloidosis, or ATTR amyloidosis, the protein is either normal or, if you like, unmutated transthyretin in wild-type ATTR amyloidosis, or in hereditary ATTR amyloidosis, the amyloid fibril protein is mutated or variant transthyretin. Why do we worry about the amyloid type? Well, basically, these different amyloid conditions, these different types of amyloid have very different clinical phenotypes and different prognoses, and they're treated completely differently. So it's essential in every case of systemic amyloidosis to determine what type of amyloid one is dealing with in order to treat it appropriately. That is largely because the treatment paradigm for all types of amyloid revolves around reducing the supply of the amyloid fibril precursor protein. So if one successfully reduces the supply of the relevant protein, the relevant amyloid forming protein that is circulating in the bloodstream, that leads to clinical benefit. And you'll hear a lot more about that later on today. Systemic AL amyloidosis is an extremely heterogeneous disease, and that's one of the challenges in terms of diagnosis. It can present to pretty much any physician from any specialty. And you may get one patient who presents to the liver physicians with a massive liver, and in the context of a monoclonal gammopathy, about 50% of patients will present with renal disease, and they'll usually have heavy proteinuria, and a kidney biopsy shows amyloid. And when you type it, it turns out to be AL. But it can present with neuropathy, it can present with soft tissue amyloid, macroglossia, periorbital bruising, as you can see here, neuropathic involvement. It is extremely heterogeneous, as I say, and that makes it interesting from our perspective as amyloidologists. It means that no two patients with this condition behave entirely in the same way. But at the same time, it also makes it challenging in that you can't consistently say a patient will come to the cardiologist or a patient will come to the nephrologist. They can present in any shape or form, essentially. Transthyretin amyloidosis, the other common cause or common type of amyloid that we see, if you like, as I mentioned, can be wild type, in which the protein is unmutated. And that is essentially an increasingly recognized cause of heart failure in the over 50s. And this panel that you can see on the right shows the massive increase in diagnoses of wild type ATTR amyloidosis in our national center. And I think this is reflected throughout the world. This condition, which was previously thought to be exceptionally rare, is being diagnosed left, right, and center in older individuals who present with heart failure. It's progressive and fatal over the course of 3 to 10 years. There are a number of extra cardiac features, but the phenotype is very much dominated by the cardiomyopathy. A pretty interesting statistic is that autopsy studies indicate that cardiac ATTR amyloid deposits are present in up to 25% of men over the age of 80. Now, the vast majority of those individuals are not diagnosed with an amyloid cardiomyopathy in life. We know that many of them are still being missed, and that is consistent with the rather poor sensitivity of echocardiography for diagnosing this condition. But what we really don't know is how many of those individuals have amyloid deposits that are clinically insignificant. So we really don't know what the true prevalence of this condition is. Hereditary ATTR amyloidosis causes usually a mixture of cardiomyopathy and neuropathy. And there are in fact more than 130 amyloidogenic mutations of the TTR gene associated with hereditary ATTR amyloidosis. The commonest one that we see in the UK, and probably the commonest one in the US, is the V122I TTR variant, which causes a dominant cardiomyopathy. Now that mutation is present in just under 4% of African Americans. So this condition is probably not uncommon in elderly US patients presenting, Black patients presenting with heart failure. Another mutation that we see quite commonly in the UK is the ALA60 or T60A, which is associated with a mixed phenotype. Patients typically get cardiomyopathy and neuropathy, both peripheral and autonomic neuropathy. And the pie chart here on the right just shows you the breakdown of the types of amyloid that we now see in the UK. About 60% is still systemic AL, and that's remained pretty constant over the years. But 30% of patients are now ATTR amyloidosis, the vast majority of whom are wild type ATTR amyloidosis. So let's turn our attention to the questions that I was asked. Well, the big problem that one faces in ATTR amyloidosis and AL amyloidosis, the commoner types, and indeed the rare types, is delayed diagnosis. This is a study that we performed in the UK in ATTR amyloidosis, showing that 42% of patients waited for more than 4 years after the onset of cardiac symptoms before their ATTR amyloid cardiomyopathy was diagnosed. And the median number of hospital attendances amongst those patients was 17 before they were diagnosed with this condition. It's very much the same. There's been a similar study across the pond where you are, and the situation was very much the same. The same is true for neuropathy in hereditary ATTR amyloidosis. 1/3 of patients being misdiagnosed, leading to delay in diagnosis. So a delay in diagnosis is really a huge problem. And on the right here in AL amyloidosis, you can see that the outcomes have improved over the years pretty dramatically with improved treatments of the monoclonal gammopathy, better chemotherapy agents. But what really hasn't changed is this early mortality of up to 30% of patients who die within 1 year of diagnosis. And those patients are patients who present and are diagnosed with advanced cardiac amyloidosis. And they've invariably had disease for quite some time before being diagnosed. So really, I think what I'm trying to highlight here is that the real problem, or one of the predominant problems, is a delay in diagnosis of amyloid cardiomyopathy. The second problem that I'd like to highlight is nicely illustrated by a case that we have, and I suspect that most of the amyloid centers around the world have got similar cases. So this is a 50-year-old Caucasian male who was referred to the nephrologist locally with nephrotic syndrome in the context of a subtle IgG lambda monoclonal gammopathy. He had no family history of amyloid or kidney failure, had a kidney biopsy which confirmed amyloid, had a bone marrow biopsy which showed a low-level plasmacytosis, and had a high-dose melphalan stem cell, received high-dose melphalan and an autologous stem cell transplant for AL amyloidosis, and was subsequently referred to us at the Amyloidosis Center. And we saw him about a year after his stem cell transplant, and at that time, he had a creatinine of 98, he had no edema, but his proteinuria had increased, despite the fact that he'd achieved a complete clonal response, which is pretty unusual. He had no evidence of amyloid in his heart. An SAP scan, a scan to look for amyloid in visceral organs, showed amyloid in the spleen and kidneys, and we got his biopsy sent over, and we performed proteomic analysis on his biopsy and did some genetic analysis, and eventually identified the fact that the diagnosis was in fact hereditary fibrinogen A alpha chain amyloidosis associated with a particular genetic variant. So this patient had received an unnecessary chemotherapy and stem cell transplant for a completely inappropriate indication for presumed AL amyloidosis when the patient had a different type of amyloid. So I think that's another problem that is rare, but nonetheless something that we need to address. So why the difficulties in diagnosis? Well, I've highlighted already the fact that echocardiography is poorly sensitive and specific. And the other problem is that amyloidosis is traditionally at least a histological diagnosis. And whilst it's easy for a nephrologist who sees a patient with proteinuria to do a kidney biopsy because that's routinely undertaken in clinical practice, cardiologists and neurologists, for example, will rarely do a biopsy to investigate heart failure or a peripheral neuropathy, respectively. It would overwhelm them. One can do a screening biopsy, and in the old literature, you will be aware of rectal biopsies. More recently, many centers do abdominal fat aspirates. But one of the challenges, particularly in ATTR amyloidosis, as you can see here, is that a fat biopsy is poorly sensitive in patients with ATTR amyloidosis. So this paper showed a beautiful paper from one of the speakers from later on today, which showed some of the red flags to try and increase awareness, if you like, and the red flags for an early diagnosis, particularly of ATTR amyloidosis, but many of them are true for cardiac amyloidosis in general. One of them is focusing on echocardiography to perform tissue Doppler and look at apical strain, or look for apical sparing in terms of the strain pattern on tissue Doppler imaging. So I think, adding tissue Doppler imaging and looking at strain in any patient, at least with a thick-walled heart, should be something that is done more routinely, certainly, than it is in the UK. Similarly, to look for the infiltrative phenotype within hypertrophy on an echocardiogram is an important thing to do if one is considering cardiac amyloidosis, or at least to exclude cardiac amyloidosis. Another important point is that in the old literature, one always heard about small voltages on the ECG. And many cardiologists will think that if a patient hasn't got small voltages on the ECG, they don't need to worry about the possibility of amyloidosis. Well, certainly in ATTR amyloidosis, a very significant proportion of patients will have normal voltages. And so small voltages, although they can be a clue, the absence of small voltages, reduced QRS voltages on the ECG, does not exclude cardiac amyloidosis. And then the other important thing is to think about other organs. Amyloid is a multi-system disease. So in a patient with cardiomyopathy, for example, is there any evidence of carpal tunnel syndrome? Is there any evidence of neuropathy, polyneuropathy, autonomic neuropathy, and vice versa? If a neurologist is seeing a patient with a peripheral neuropathy, is there evidence in the history of a cardiomyopathy of some kind? So really, the consideration of multi-system disease and not simply sticking to your own specialty, as it were. So what else has made a difference in terms of early diagnosis? Well, some 15 years ago, we performed a study in 29 patients with cardiac amyloidosis in collaboration with Dudley Purnell at the Royal Brompton Hospital. And what we found is that you get this very, very characteristic picture on cardiac MRI with gadolinium of delayed gadolinium enhancement. And the reason for that is very straightforward. Gadolinium doesn't get into cells, and it takes longer, therefore, to diffuse through this expanded extracellular space, which is expanded by the amyloid deposits. On the right here, you can see that this extracellular volume is increased par excellence in amyloidosis compared to the other hypertrophic cardiomyopathic conditions, if you like. So amyloidosis is really the condition par excellence that gives you this late gadolinium enhancement and is practically pathognomonic of the condition. Now, the other imaging tool that has helped early diagnosis, I think it's fair to say, is bone scintigraphy. In the UK and in Italy, we use DPD, but in the US, you use PYP. France and various countries use HMDP. And there have been reports in the medical literature for 30 odd years of a patient who has a bone scan for whatever reason, and whose heart lights up, and they turn out to have amyloid. And about 10 years ago or thereabouts, Claudio Rapezzi, a cardiologist from Bologna at the time, started to look at this more systematically. And he came up with this grading system of cardiac uptake that was equal to or less than bone, grade 1, cardiac uptake that was more than bone, grade 2, and cardiac uptake that was more than bone with very marked bony attenuation. You can hardly see the ribs, and you can hardly see the long bones in this patient with grade 3 uptake. And what he found, and what's subsequently been reproduced in many, many centers, is that bone scintigraphy is exquisitely sensitive for diagnosing cardiac ATTR amyloidosis. And some years ago, in collaboration with many amyloid centers around the world, we established a means of non-invasive diagnosis of cardiac ATTR amyloidosis by following this shaded area. And I'll take you through it with a patient. So this is a 66-year-old Caucasian chap who had a history of atrial fibrillation, spinal decompression, heart failure with thickened LV walls, who was referred to us with a suspicion of cardiac amyloidosis. When we saw him, he had elevated biomarkers. He had a characteristic amyloid echocardiogram. We did a bone scan, a DPD scan, and he had grade 2 cardiac uptake on his DPD scan. We then did 3 tests to exclude the presence of a monoclonal gammopathy or a subtle plasma cell dyscrasia, serum immunofixation, urine immunofixation, and the serum free light chain, all of which were normal in his case, no evidence of a plasma cell dyscrasia. And on that basis alone, we were able to establish the diagnosis of cardiac ATTR amyloidosis. And following genotyping, we were able to make a firm diagnosis of wild-type ATTR amyloidosis. And in this large study that we undertook, which was a collaborative study of over 1,000 patients, 350 of whom had had endomyocardial biopsies, this non-invasive diagnostic algorithm, if you like, was 100% specific for cardiac ATTR amyloidosis. Now, I'm not pretending anything is actually 100% specific in clinical practice, but what I can say to you is it's extremely specific as long as the algorithm is followed to the letter. And I just want to reiterate the need for doing all 3 of those tests to exclude a monoclonal gammopathy. This is another patient, a 72-year-old chap referred to us with cardiac AL amyloidosis in the context of a low-level IgA lambda paraproteinemia. We found him again to have elevated cardiac biomarkers and heart failure, and an echocardiogram and CMR that were characteristic of cardiac amyloidosis, a grade 2 DPD scan, but he did obviously have evidence of a plasma cell dyscrasia, an IgA paraprotein, and an elevated lambda light chain. So at that point, we need histology. He doesn't fulfill the non-biopsy diagnostic criteria. At that point, the differential diagnosis includes AL or ATTR cardiac amyloidosis. So we undertook a fat aspirate. There was no amyloid in it, and he proceeded to an endomyocardial biopsy, which confirmed ATTR amyloid. So the final diagnosis was that of wild-type ATTR amyloidosis, and in this patient, no role for chemotherapy. It was not, as previously suspected, AL amyloidosis. So just to recap on an important point, the role of radionuclide cintigraphy in cardiac amyloidosis. If you see diffuse cardiac uptake, you can be very confident you're dealing with a patient with cardiac amyloidosis. But having said that, the absence of cardiac uptake does not exclude cardiac amyloidosis. So in about 40% of patients with cardiac AL amyloidosis, you have no DPD uptake at all. So you can't exclude cardiac amyloidosis on the basis of a DPD scan or a radionuclide scan. Similarly, grade 2 or 3 cardiac uptake in itself does not equal cardiac ATTR amyloidosis. About 10% of patients with cardiac AL amyloidosis will have grade 2 or 3 cardiac uptake, so you really need those 3 tests that I mentioned to exclude a plasma cell dyscrasia before you can make that diagnosis of cardiac ATTR amyloidosis. So let's turn our attention to the second problem, which is that of amyloid typing, determining the amyloid type, which, as I mentioned, is essential if you're going to treat the patient correctly. So the methods available to us are either direct fibril sequencing, but for that one would need a substantial quantity of frozen tissue. It's not routinely available in clinical practice. Electron microscopy and immunogold is not widely available. And the preferred method in clinical practice worldwide is actually immunohistochemistry for determining the amyloid type. but that has variable sensitivity and specificity. So, for example, in non-AA type amyloidosis, we get up to 30% false negatives. So in AL amyloidosis, typically up to 30% absence of staining with an antibody against kappa light chains or lambda light chains. There may also be high background, particularly in the context of a plasma cell dyscrasia. 5% of the population over the age of 80 have a plasma cell dyscrasia. And as you saw from my earlier example, the presence of a plasma cell dyscrasia plus amyloid, although means AL amyloidosis is very likely, it doesn't prove it. You need to prove that the amyloid is actually composed of that light chain. Here, the panels at the bottom, you can see a patient with Congo red staining under bright field light, Congo red under cross-polarized light showing the green birefringence, and then stained with an antibody against kappa light chain. You can see specific staining here, but you can also see staining with an antibody against ApoA1. So the immunohistochemistry here is inconclusive in itself, and that's part of the problem. So some years ago, the Mayo Clinic pioneered this technique of laser capture microdissection and mass spectrometry. And the beauty of this technique is that you can determine the fibril protein from formalin-fixed paraffin-embedded tissue and a very small quantity of tissue at that. And the beauty is that can be sent around the world. Your block of tissue can be sent around the world and to a center that performs mass spectrometry, and you can get your diagnosis on that basis. The principle is that you chop out the amyloid, you stain your tissue with Congo red, you chop out the amyloid using a laser capture microdissection microscope, you digest your amyloid with trypsin, you separate the peptides by HPLC, and then run it through a mass spectrometer, and on the basis of the mass spectrometer, you identify the proteins that are present in your tissue. And in this case, the presence of serum amyloid P and apolipoprotein E are two of the what we call amyloid signature proteins. So they tell you that you're dealing with amyloid, and then you look for an amyloid fibril protein, in this case, transthyretin. Now, this is the algorithm on the right that we follow in the UK to achieve the right diagnosis through mass spectrometry. So it's not a piece of cake. There are challenges, but nonetheless, if it's correctly performed, you can correctly and definitively identify the amyloid type in more than 95% of patients. So to summarize, cardiac amyloidosis should be suspected, I would say, in any patient with a thick-walled heart and heart failure. Diagnostic delays, as you saw, persist, and what we really need more than anything is increased awareness of the red flags, and for people to think this could be amyloid in any patient with multi-system disease, and in particular with a thick-walled cardiac disease. From a cardiac perspective, look for the infiltrative phenotype within hypertrophy on echocardiography, do strain, CMR and radionuclide bone cintigraphy, I think, are important imaging advances that have made a big difference to number of diagnoses and also timely diagnoses. ATTR cardiomyopathy is an increasingly recognized cause of heart failure in individuals over the age of 50, but the true prevalence remains uncertain. The non-biopsy diagnosis of cardiac ATTR amyloidosis is possible in about 70% of patients, and identification of amyloid by Congo red staining must be followed by typing of amyloid, which, although worldwide is still probably most commonly done by immunohistochemistry, can be done by proteomic analysis, which I think represents an important advance. So thank you very much indeed for listening.
Thank you so much, Dr. Gillmore. That is really just a fantastic overview of what is very complex. And you're exactly right. The case that you showed of somebody who got a stem cell transplant for TTR amyloidosis. Unfortunately, that story has been played a few times in my own personal experience. So I think we obviously need to be very careful about making the diagnosis. So that was really beautiful. We have like 1 minute, and then we'll have some questions, I'm sure, for you afterwards. But there's sort of two main questions that I would ask you about in particular because of your experience. You mentioned in your presentation about a SAP scan, so I would like just a little explanation about that. And then you also highlighted that a TTR scan or a pyrophosphate scan that we do in the US and a DPT scan that may be done in Italy or other locations, you say that they're very sensitive if markedly positive. But is there any difference in those tracers in terms of one versus the other as to how sensitive they are? Like in the US, is our scan inferior in some way, or what do you think?
So I'll answer the second question first. I mean, there hasn't, as far as we're aware, there hasn't really been a direct comparison of the different tracers. What we do know from our own experience in the UK is that certain bone tracers seem to be less sensitive than DPD. So we will get patients occasionally who've had an HMP or certain other tracers, not including the three that I mentioned, bone tracers that do seem to be less sensitive. But between DPD, HMDP, and PYP, I am not aware of any data to suggest that any one is less sensitive than the other. What I can tell you is that DPD is exquisitely sensitive, and my understanding from Matt Mara and various people who have used PYP in the US is that it's extremely sensitive, equally sensitive. So I don't think there's any good data on that as far as I'm aware. Answering your first question, SAP cintigraphy is a technique that we developed here in the UK. SAP is a minor constituent of all amyloid deposits. So not to be confused with SAA, serum amyloid A protein, the protein that makes the amyloid fibrils in AA amyloidosis. SAP is a minor constituent of all types of amyloid. And we basically radiolabel that protein, a small quantity of SAP, and inject it into patients, and it binds to their amyloid. And because the SAP in the bloodstream and the SAP in the amyloid is in a dynamic equilibrium, it binds in relation to the quantity of amyloid present. So it's a great diagnostic technique for visceral amyloid deposits, but it has its limitations. For example, it doesn't show up amyloid in the heart, it doesn't show amyloid in the nerves. So it has its limitations, but it's an additional diagnostic technique which can be useful, but is only currently available in the UK.
Super. Thank you so much.